Good morning, everybody. We have Dr. Ram Chadha today with us, talking to us about the clinical approach to a patient of chronic low back pain, discussing degenerative disc disease and lumbar canal stenosis. So,
Good morning, friends. Look at a case. 45-year-old gentleman, chronic low back pain, 4-day history of severe right more than left leg L5 pain, neurologically L5 grade 4 by 5 MRC. How do we look at this patient? What you see above is what the disc would look like had I taken it out. Would you conserve or operate this patient? In the early stages of practice, we are very happy to see such patients because they are the most lucrative patients for surgery. And these are patients who will be extremely happy if they get instantaneous relief. However, I share with you something which I can now stand up and say why we should not operate this patient, and that too not immediately. Let's look at the natural history of the herniated disc fragment. Various studies, herniated discs subside in majority of cases. 85 was the first time that they reported regression in 11 cases. That time there were CT scans. MRI was not really available. In 1995 with MRI, they showed regression in 62% of the cases. An interesting study at the end of 2 years plus 1 month, 25 months, done by two brothers, the Sal and Sal brothers, who also then spoke about automated percutaneous lumbar discectomies. Almost 50%, 49% discs show 75 to 100% resorption in 25 months. 39% show 50 to 75% resorption, and 12% show less than 50% resorption. Do you realize that even if there is a mild shrinkage of the disc, even 0 to 50%, the nerve root will get offloaded and the patient may get asymptomatic. So there is a huge place to avoid surgery and probably wait for the natural history of shrinkage of the disc. How does this happen? Well, nucleus pulposus fragments cause an inflammatory response. Interleukin 1, 6 and the other prostaglandin mediators cause a macrophage infiltration, neovascularization, and the disc tends to get resorbed. So it's not the patient alone, but the treating doctor, you and I, who need to be patient and wait for this to happen. Factors which affect disc regression. Please understand, because this may be contrary to what you have assumed till date. Discs which regress are usually more degenerated than the younger discs. The greater the size of the herniated fragment, the higher the possibility of shrinkage and regression. Young disc bulges do not regress as well as elderly extrusions. So that ghastly looking fragment which I showed you in one of the images earlier, possibility of that getting apoptosed, shrunk, microphage absorbed is much higher than a young disc with a foraminal bulge which may cause unbearable pain and may not shrink as easily. There's no correlation between the site of herniation and regression. Does radiological regression correspond to clinical symptoms? Another very interesting study. You must understand that almost in 150 days, more than 90% of the discs will regress, but improvements in clinical findings will be much before the improvement in the MRI. Again, go back to that mantra, treat the man and not the scan. Do not wait for the MRI to improve. An interval MRI may be done at 3 months, 6 months, 1 year. But if you're clinically better, believe that the shrinkage is occurring and the patient will ultimately